Inviting on stage Dr. Ravi Gopal Verma, Dr. Raghuram G, Dr. Guru Prasad H, and Dr. Anand Balasubramaniam. To begin, Dr. Raghuram G will introduce the orator. Please join me in welcoming Dr. Raghuram G.
Good morning. Thank you all the faculty and the delegates for coming to the conference that we are hosting and making it such a grand event. We had a great day yesterday in the workshops and hope to have much more interactive meetings in the next sessions. The first few sessions were amazing talks. So it's an honor and privilege for me to be giving the introduction to Dr. Professor Paresh Doshi. He is the Director of Neurosurgery and Stereotactic and Functional Neurosurgery and also the Director General of the Restorative and Regenerative Medicine at Jaslok Hospital and Research Center, Mumbai. He has been a guru to me and it's really a privilege for me to be introducing him to this august audience. So we all know that Dr. Doshi has been a trailblazer in functional neurosurgery. Especially for India, he has driven by a great visionary zeal to bring these advanced international therapies to India. He did his MBBS and MS both from Ahmedabad. He was a gold medalist in the MCH neurosurgery at the T.N. Nair Medical College in Mumbai. He trained in functional neurosurgery by the doyens in the field. He has visited every big neurosurgery group that was doing functional neurosurgery and epilepsy surgery at that time in various hospitals, including the National Hospital for Neurology and Neurosurgery in Queen's Square, London, Maudsley, King's College Hospital, London, and the Newcastle General Hospital, and spent almost 4 years, refining and making all this excellent work that he's been doing. He's been trained by the doyens, like I already told you, including Professor David Thomas, Professor Marvin Harris, Professor Aviva Bosch, Professor Benabid, who is actually the pioneer of DBS in the world. So he has been trained by the real great, fine pioneers in the world, and Professor Mark Sindhu, from whom he learned a lot of technique about spasticity surgery. In 1998, he returned back to India, rejecting a lot of lucrative offers to stay back in England and other places. So he decided that he wanted to establish this neurosurgical subspecialty in India and take it to great heights that he has been doing all these years. He established the research facility in Jaslok as early as 2003, and he has worked relentlessly to gain international recognition for Indian work and Indian neurosurgeons. And we all know that, especially in our field in functional neurosurgery, that how much India is recognized as a functional neurosurgery space is primarily to Professor Doshi's efforts and hard work. He has placed India on the global map for functional neurosurgery, and he's always been very passionate about training and teaching young neurosurgeons. The first fellowship training program in India in functional neurosurgery was started by Dr. Doshi in 2010, and he has trained more than 17 neurosurgeons from India and abroad. He hosted the prestigious WSF interim meeting in Mumbai in 2015, when many thought that India would never be able to host such an international meeting. I was part of that meeting, and I can tell you, it brought the whole galaxy of functional neurosurgeons from across the world, state-of-the-art papers, and it was an excellent meeting and attended by a huge number of surgeons from India and abroad. He also held the INS interim meeting in Mumbai in 2022. Coming to his other efforts, obviously such a well-read and researched person has published more than 16 papers in multiple peer-reviewed prestigious journals. He has delivered more than 600 lectures at various national and international meetings, and he has important executive posts in various international societies. He is the present secretary of the WSSFN, which is our parent body or the parent world body. He is the president of the Neuromodulation Society of India. He is a member of the World Society Task Force of Neurosurgery for Psychiatric Disorders. And he is also the board member of the Asian Oscillation Society and the past president of our ISFN. This is just to give you the kind of papers that he has published. You can see all are very, very multiple times quoted papers in all important journals. This is in neuromodulation. This is a very, very favorite topic of him, and he has worked so hard for setting up this. I think Dr. Dwarka is not here, Dr. Janardhan Reddy, and all of them, they have worked so hard to take surgical interventions in psychiatry to the next level in India. They published this paper. He is also a part of international legal approaches to neurosurgery for psychiatric disorders. This was another paper that was published in Frontiers of Human Science. The kind of papers that he has published, some of the side effects of DBS has been first described by him, and then they have been accepted, and multiple people have quoted and accepted the same kind of effect that they have seen. He's also done many firsts in India. So this is a long list, so I'm not going to go through all of that, but all of you can see he has been the pioneering therapy that he has done to improve the quality of life of the patients. In addition to the accolades from the academic field, he's also been very active on the social front. He has done a lot of things. He's established a Parkinson's Trust in Jaslow, and he's also been awarded by all these groups. He was the Indo-American Society Young Achievers Award in 2002, CNN, IBN, Times Group, and Medscape India have given him multiple awards, the Pharma Leader Brand in 2019 awards, and even the FICC Medical Value Travel Award. This is a very special picture. So in 2024, the Rajasthan University of Health Sciences conferred a PhD medicine honoris causa, recognizing his exemplary work in neurosurgery and in the field of neurosurgery. He's obviously a very, very well-respected person in the World Society, so we are all very proud of that. And so this was at the World Society meeting. Dr. Ravi and myself and many of our other Indian colleagues, we were all there at the 2022 WSFN as well as the 2024 WSFN. He is a very, very approachable and very friendly person. So you can see that we had all these pictures at the WSFN 2022. In addition to this, zeal for learning has not stopped. So it's not like, okay, I have achieved so much in DBS, I don't have to do neuromodulation, I don't have to do anything. Even now, he has now started a very, very interesting department in the Department of Restorative and Regenerative Medicine at Jaslow. And the next picture, this is with the picture of the trustee, Colonel Masan. This is his wife, Dr. Doshi, and this is the CEO of Jaslow. So he has worked with Jaslow for 28 long years. So imagine the kind of sincerity and the effort that he has put in that department to get it to world-class standards. He's also a very, very close family man. So Dr. Preeti Doshi is also the secretary of the society, and she's a very active person. So you must have all seen her and met her at various meets. So they are the neuromodulation couple of India. This is how to show that. So this is the department at Jaslow. You can see this is the research wing, this is his office, this is the whole team. You can always see that it's a huge team which works to make sure that we get to know and learn and improve our quality of patient's life. So this is just last picture to show you. So this was the first TNS meeting which was held at Guwahati, and from there he has had multiple, I think this is the third meeting, and we are doing very well. And this was his recent patient, so he's always trying to help patients. So this was an 81-year-old DBS patient who did well after surgery and came back to cut a cake at his department. So what we say in our culture, Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Gurave Namah. So it's a honor and privilege, sir, and you have been our guru, and we know that you have helped us so much in improving therapies, learning therapies. Thank you so much. Wish you all the best, sir.
Thank you, Guru Prasad. It was really a talk from the heart and overwhelming, and it makes me a little emotional also, the last few slides. I don't know what I deserve, but it's nice to know that your students or colleagues appreciate you. I would like to first congratulate Guru Prasad and Dr. Raghuram for putting in tremendous effort. We have been a real pest to them, especially more Preeti than me, because I was slightly busy with other work, but every day messages, every day communication to put in this Congress together, and they responded well. And I think if next person wants to organize, they should learn and take a leaf from that book. And I'm very proud to say that I can see a very successful meeting that is being conducted by a multidisciplinary team here. I got compliments from interdisciplinary people from psychiatry, from other allied branches, who showed their and expressed their feelings about how they felt that this is actually a multidisciplinary neuromodulation platform that we have brought in together. Okay, so I chose this particular topic to talk about the new technologies. We heard a lot in the morning, we heard many people saying, but how does this impact, or how would this change our clinical practice, or how can we bring these things within our clinical practice ambit? So what are the things that we can think about? Technological advances have occurred, and these are the things which are already available, and there will be few things which will be around the horizon, and now things don't take 20 years to come. It takes 5 years. So we have to move very quickly, we have to move very fast. So technological advances, directional lead, MRI compatible devices, image guided programming, LFP based programming, we all have been hearing about it. Programming advances, new programming technologies. 3 years back or 4 years back, I saw the early papers coming into the literature of using lower pulse width to help improve or reduce the side effect, or using variable frequency across various, both electrodes to help tremor on one side and freezing on another side. And all of them are now being a common practice in the medical programming, neurological programming thing. Remote programming, it has been, I think, cleared by FDA in US for Abbott. And now in India, we don't have Abbott, but we have Chinese devices which offer that. Techniques have changed, asleep DBS, frameless devices, and robotic DBS. I had been in one of the meetings where one of the leaders of the world functional neurosurgery mentioned that people are trying to move towards the daycare DBS surgery. And I also recently heard that some center in India tried to do that as well. So moving very fast, at a fast pace, we require to understand the benefits and pitfalls of that. Technological advances, we'll talk a little bit on this 70 MRI, and programming advances which are likely to come very soon. So let us go into the technological advances. This was one time considered to be difficult thing, and how we will be using it and all that. And when this was being presented, I still remember 2 and 3 years back, the neurologists used to get scared that it is anyway difficult to program 4 contact points. How are we going to program 8 contact points? And then the companies came to their aid. They started developing image-based programming. They started using the pre-operative MRI data sets and try to reconstruct it and show you the STN. One important caveat, these are automated programming techniques given to us by the industry. And what they show here, you can see, is that STN is very well depicted, but this STN was actually not where the computer program showed us. So it is very important for the young colleagues to understand that do not take everything that the computer shows as a tablet in stone. You have to evaluate yourself. For example, this particular STN has been modified by my team to suit the STN that we think is there. Because if this STN is shown here by the image guided, then you would be outside the STN. And then the next step the image guided programming does is to take your post-operative CT scans, superimpose and reconstruct the DBS lead, and also the direction of the DBS lead. So now you have both the things. You know the contact points which are within the STN, and also you know which direction it is following. If you are using DTI, and which we will start using it very fast, I will talk about it later also, but basically when you start using DTI, it can help you to see the relationship of the electrode, target, and the fiber tracks. And then the last thing, which is most important, is to see the volume of tissue activated in relationship to your stimulation. So as you increase the stimulation here, you can see the expansion of the VTA or the area of stimulation, and you can modify that as required. And how do you modify that, and what can happen with the modification, I will show you in the next video. So this was done before we had this new software which has just come few months back, where we use DTI and other things, but this was a clinically based directional lead programming, and you will see the difference. Sound. Little. Small sound. Yes. Because he's speaking in Tamil. Post DBS, you can see there is a fantastic motor improvement, but he has gone into a manic phase. He is very hyper. Samir showed us what happens with OCD programming. Similar things happened here. He became in a manic phase. So what we did was re-evaluated it, and you can see that he was having double monopolar contact on left HCN and single ring electrode on the right. So we reprogrammed him. And here we used the directional lead to avoid this contact and continued to stimulate the right electrode. And the result was that he became much more better.
A period of 30 years is more. And
PD was very well controlled, and we looked at him on the next day, and he continued to remain better. So then we go to the second type of image-guided programming, a step ahead. This is a completely automated programming tool. You just tell the computer what you want, and the computer will tell you what to stimulate. And let me explain you how. This work has been done by Dr. Shamir Sheth and his team, and here they used DBS Illumina 3D algorithm, which uses a patient-specific imaging to find stimulation setting and optimize the activating of the target area. This uses the preoperative patient's data set, and then it superimposes on the target area the volume of tissue activated. You can then define that suppose you want to stimulate STN, dorsal part, you define that this is the area that I want to stimulate. You define the internal capsule and tell that I want to avoid this. And not only that, you can tell the percentage of avoidance also. How strongly you feel about avoiding it. And this is going to be important because there are new papers coming about the proximity of the target tract and how much to avoid and how much not to avoid. Once you have told that, the computer generates a map of stimulation and tells you. So Samir and his group compared this to a standard patient in depression. They did it in 3 patients, and you can see that this was a conventional method where they had stimulated the electrodes at 2 sites, and this was the volume of tissue activated, slightly eccentric, but based on the image-guided programming, they were covering very well the target area, but there was a spillover. The problem about DBS, neuromodulation, now everybody is thinking is getting good response is fine, but want to avoid the spillover effect, want to avoid the long-term carryover effect, long-term complications because of chronic stimulation. So what do you do? So they set this thing into the Illumina 3D, and they could find that this was a complex programming which a human would never be able to throw up. This kind of combinations will never be able to come up with the programming. And this program threw this up and showed us that they both had the similar stimulation effect of spill volume and stimulation, but this was better because the spill volume with Illumina 3D was better as seen in this box plot. We did a step lower. We examined this as a semi-automatic algorithm. So I showed you a fully manual first, then a fully automated algorithm. This is a STIM search. It is a third semi-automated algorithm. So we evaluated this in our lab, and what we did was we selected 10 patients of Parkinson's disease who had a good outcome. Then we decided that let us examine this with an algorithm guided programming, AGP. So we switched them their medications off, stimulation off, and programmed them as if they had just undergone DBS with the help of algorithm, stabilized them, conducted UPDRS examination, and saw what would the patient prefer, what was the difference between a standard of care SOC program versus AGP program, and what was the amount of volume of tissues stimulated. So as I said, the method of this algorithm guided programming includes you assess the patient's PD symptom and tell the computer that how much improvement you feel. Then the computer tells you to go to the next point. Then you again assess and tell what is the percentage of improvement you have felt in this patient. So you are allowed to give a percentage improvement and also the weightage to that particular symptom. Suppose I feel that rigidity is one of the most important parameters that I want to focus. So I say the priority is high. I say tremor, priority high. Bradykinesia, I am not so much worried. I say priority medium. And the computer algorithm calculates all these things in a matrix and keeps on giving you next point, next point, next point, next points, till you reach a place where you say, okay, fine, I am satisfied. Or all the symptoms that you have mentioned that you are looking for are corrected. That is when the computer stops searching for a new point and gives it. Again, based on the previous kind of programming, it uses clinical input to guide you to the next step. So what results we saw? We did not see any difference between standard of care and algorithm guided programming in terms of UPDRS. Average programming time, it was 14 minutes. And 70% of the patient preferred algorithm-guided programming. So you can question that though there is no difference in UPDRS, why would the patient go back to the algorithm-guided programming? The reason was the first Illumina study I showed, the side effects spillover. Maybe there was some spillover into some areas of the brain which we are not able to document. We are not able to document everything today. So it could be some apathy, some speech disturbance, some gait disturbance, which cannot be documented in UPDRS every time. So that, but the patient feels it improves quality of life, so they chose the algorithm-guided programming. So that is how, and the volume of tissue activated, you can see here, we did the overlay of the stimulation field map. The orange is the STIM search or the algorithm-guided programming, blue is standard of care, and both of them are stimulating similar areas. And these things we will discuss in next few more slides. This is a dice coefficient to evaluate the difference between these two. They did not show much difference, and the overlap of STN areas was also with standard of care and algorithm-guided programming same. This is more of like a statistical measure, and the other one was a pictorial measure. And then remote DBS programming, we all know, patient can be sitting at home and you can use Bluetooth devices to program these patients sitting in your office. So that is going to be useful. Advanced programming methods. I think one of the speakers mentioned about chrono reset. And chrono reset is some new kind of neuromodulation which is trying to bring desynchronization. And I think Samir also mentioned synchronization is the problem here, and desynchronization is what we want to achieve, and that is what we have seen. The desynchronization in the STN, either with levodopa DBS, results in a decreased beta band. So they used a chrono reset parameters or this programming technique wherein the impulses are not delivered at one contact point. We are used to delivering in 1 or 2 contact point in a continuous stimulation manner. In chrono reset, we deliver it at 1, 2, 3, 4 at staggered manner in all 4 contact points at different time intervals in a sort of cycles, and then there is a pause, then again cycles, and this has helped to achieve desynchronization that is important and maybe improve rigidity, tremor, and bradykinesia, and that may have a carryover effect. This is still not, this is a concept. I don't think there has been very research done or lab done on that. Last, I would like to talk about adaptive DBS stimulation. We all have been talking. This is a preprint paper coming from a group of stalwarts who have been actively involved in the research of adaptive DBS, from Fasano to Jens Walkman, Joachim Kraus to Andrew Lozano and Michael Okun. And they selected a panel of another 13 people to make it 21 people who all have been actively invested in the research of this field. They evaluated and they used the Delphi construct to reach a consensus on this, because it's not easy to have 21 intelligent people agreeing to one point. So they went and used the Delphi construct, and they had 3 rounds of Delphi questionnaire circulation before they could reach a consensus, and despite that, they could reach consensus only on few statements. Adaptive DBS has a technological limitation, but that the current pacemaker technology is ready for clinical use. They strongly agreed that it requires a very high level of expertise. They strongly disagreed its feasibility, and so that means they said that it is not a substitute for a misplaced lead. And they agreed that DBS may lead to faster, stable treatment response after the initial settings. So you have to have a good initial settings and then they can improve. Sorry, I think, And then on the clinical side, they reached a 4 or 5 further conclusion. The use of adaptive DBS technology for tremor-dominant Parkinson's disease, they approved. Adaptive DBS, they again reinstated is safe. They felt that to enter into a routine clinical practice, it may take up to 10 years for everybody to use it regularly, but it has a positive long-term impact on the patient, will be useful for motor fluctuation and significant dyskinesia. That these are the indications. They felt that they will benefit from adaptive DBS technology and agreed that it may lead to a faster, stable treatment response time after the definition of stimulation settings. We come to the next part, and that is a tractography-based targeting and programming. Now, tractography is going to change the way we look at it, and it all started, it started long back. It's not started with this, but most important requirement was to find out where is the medial forebrain bundle, because we can't see it on the MRI, we have to imagine that it will be here. So these guys, Walker Koinen and his group, started looking for it. They were very much interested in SLMFB, and they wanted to target this for depression. Based on that work, based on that work, we saw this slide with Samir. Helen Mayberg and their group started looking at the failed depression cases. They had patients who had been successful, some patients had failed, so they started looking at why they had failed, and they found out that there is a sweet spot in the brain in the same region, SCC25. But the sweet spot is a confluence of these fibers, forceps minors, cingulate bundle, uncinate fasciculars, frontostriatal fiber. And this is the actual patient planning picture where they found the sweet spot and they chose that as a target. We also used this in the recent patient of depression that we did, and we got a good outcome. So this is something that they adapted and now used it in clinical practice to improve targeting. It can also help to rescue failures. For example, this Brian Koppel and his group's paper showed that they targeted CZI, or what posterior subthalamic area CZI, they are all similar region, for patients with severe Parkinson disease and tremor, severe tremor and Parkinson disease. And they found that in one patient they got a fantastic outcome. In the second patient they did not get a good outcome. They looked at the target, they felt it was same place. Why should the second patient develop a dystonia and slurring of speech despite having this same target? So they then did a DRTT imaging, a fiber tract imaging, and they found that in this particular patient, the right side, the DRTT was slightly anterior. They repositioned it, and you can see this is the original is yellow, the green is the green is the revised one, and they could get the desired outcome. So they used it. It can be used to program patients post-operatively. Robert Curie from Sao Paulo, Brazil, used this, a neurologist, examined 23 patients of Parkinson's disease with severe pain. And we know that pain in these patients, predominant non-motor symptoms, improve after surgery. But in half of his patients, it did not improve. So what did he look at it? He looked at the connectivity of these patients retrospectively and found that the VTA connections which pointed to the prefrontal cortex and the right postcentral gyrus related to negative outcome. They also felt that a positive outcome can be achieved if the fibers were connected to the motor area, which also correlates with the better motor outcome. And then they proposed that in those patients whom you had a VTA connecting to a different area, if you shift the VTA to the areas connecting to the motor area, you may get an improved outcome. So this same fiber tracking can be used for multiple requirements and multiple purposes. I will show you here, this is a recently done, we recently had an upgraded version of a BrainLab software which now images probabilistic fiber tracking. And let me tell you, this we are doing it because of our research interest. It takes additional 1 hour apart from the DBS protocol imaging under general anesthesia to get this kind of detailed fibers, because you require a prolonged detailed study for this. So, sound please.
As far as the image-guided programming is concerned, we are in the center of the STN on contact 2, and this should give us the best effect, and that is what we found clinically. However, when we looked at the fiber tracks passing through this at the VTA that we stimulate, we could see that hardly any fibers are going to the motor area, and most of them are connected to the supplementary motor area. The motor area is...
This patient also had a tremor, and for tremor control, if you have fiber connections to the motor area, you can get a better outcome. So though the rigidity and bradykinase improved, we could further improve it, and I will show you how it happens.
Highlighted in blue here. So we tried to shift the VTA in such a way that maximum amount of fibers would be connected to the motor area. And you can see that when shifting the VTA to the posterior part, so that the direction of the current, if we direct it more posteriorly than anteriorly, we could see that large amount of fibers are now being included in the motor area, and the VTA is also shifted to include that.
So this is the way you can use the various newer techniques and technologies to improve your outcome. We already heard a little bit about the biomarkers, but I will tell you how to use them in a clinical practice. So this is an interesting patient by Wao et al., again from US. This group had a very difficult patient who had severe rigidity bradykinesia as one problem, but dyskinesia was another disturbing problem. So they tried to look at their LFP, and they found that we know that gamma band is associated with dyskinesia. So they identified this gamma band. So after correcting and medically managing and programming the patient for rigidity bradykinesia, they were still left with this off-period dyskinesia, or nearing the off-period dyskinesia, which was difficult to manage. So they used different frequency bands and use LFP to guide them which one suits the best. And you can see that stimulating at 80 Hz was not giving relief on the gamma was not coming down. Slowly, as they increased the frequency, the gamma band did come down, and they could find that the fine-tuning and giving frequency stimulation 140 Hz could help them improve. The story or the last word is not written on the biomarker. It is the beginning. The beta band is something that we all have got excited about and we have started understanding. But are there better things? So Philip Starr and his group from San Francisco started to look at cortical fine gamma. So they felt that the cortical sampling or finely tuned gamma is a much stronger predictor. Again, mind my words, these are early scientific data. There is nothing concrete in this. These are 3 or 4 cases. But yes, tremendous amount of information and science to guide us. So they found that cortical finely tuned gamma was more stable across various stimulation parameters, and it correlated better with the patient outcome without compromising or increasing the side effect. Our Dr. Shamir Sheth mentioned this very modestly, this study. This was a very elaborate and very detailed study which I was very impressed about. They had a courageous leap into the science, putting 4 electrodes for depression and 10 SEEG electrodes in the brain to gather information that can help to advance the science. And you can see here what they found was their purpose was to find some biomarkers which can help us guide the patient in the real world. So they used the information obtained from SEEG over last 10 days in the neuro ICU monitoring and various mood behavior changes in the patient, collected that data of stimulation responses, and then they fed back into the stimulator, and then they saw what improvement the patient gets. So it was a reverse engineering, but it was very effective. And then the kinematic DBS, we heard Dr. Mittal mentioned about various devices, wearable in the hand, leg. Mainly these are going to be very useful for us to manage patients with freezing of gait or gait disorders and tremors. Dual target stimulation, again that someone had mentioned, but it has been used for various purposes. Dual target, Samir used it to treat OCD and Tourette syndrome in a patient with Tourette syndrome, OCD behavior for VCVS and GPI for Tourette. Bomin Sung used it in a different way. He wanted to find out which is the best stimulation site, so he put a long extended electrode and stimulated VCVS, bad nucleus of stria terminalis and nucleus accumbens, and he found that the sweet spot is in the nucleus accumbens, bad nucleus stria terminalis borderline. Some patients have used GPI and STN DBS both together for Parkinson's disease. Some patients have used dual target for complex essential and dystonic tremor. We used it for something very unique. We had a patient with Parkinson's disease who was borderline PSP, and it was difficult. Either we cancel the surgery for him or do not offer him any treatment, or we offer him something that may last, because he had a 6 or 7 years of disease duration, 7 years, yeah. So that is why we offered him what we call it PPN plus PPN plus STN stimulation. We said that we will switch on the STN stimulation till his Parkinsonian symptoms are bothering us, and then if the freezing of gait increases, then we will give him PPN stimulation. And you can see this preoperatively, he had marked freezing of gait and typical Parkinsonian symptoms, but we were sure that he will evolve as a PSP. So usually this patient would never be offered any surgery, but then if you do not offer, then his quality of life for the next 3 years also is going to be bad. And you can see that we got the benefit over a period of time, and this is at 21 months.
Very good. Very good. Very good.
Still continued on STN stimulation.
Very good. Very good. Very good. Turn.
So we used a PPN stimulation as a backup, which we had not required to use it, and he continued to get better quality of life. And the last thing is on the 7 Tesla MRI that we have got here. You can see how beautifully the 7 Tesla MRI can delineate STN. And this comes from Jankovic's group, Gerald Wittek's group, and here they imagine 7 patients, and they could find that the STN in each patient is different. So this is very important for us to understand. They then further went in to correlate the imaging length or the dimensions of the STN in the real life, and they could find that the electrodes were within that. Not only that, their microelectrode recordings also coordinated or coincided very well with them. And further, they also correlated with stimulation-related improvement or side effect. When it was outside the STN, there was no improvement. When there was in the STN, there was a good improvement. And when there was further out of the STN, they had uncontrolled side effect. The last slide, and it is about the research. It is very important to understand where we are today. Today, where we are is culmination of 20 years of research, especially in the technological field by the 3 giants in the neuromodulation companies. Unfortunately, the work of research has started stalling in this area. And I am not sure after 5 years or 10 years how much technological advancement we would be able to see, because the growth of any science is dependent on the application. The indications are not expanding. Dr. Sheth just mentioned that they are now reinstating a depression trial. Till we expand more indication or the application of the therapy becomes more wider, it's going to be very difficult for industry to justify the cost. It took 7 years after those 2 VCVS and SCC failed trials of psychiatric disorders for another company to get courage to bring another trial. And if we don't do something for this, the cost is increasingly rising. For us as India, we should look at now developing an indigenous device. Dwarkanath did mention that it is getting prohibitive, and we have to look at it. This is my Just Look team, clinical team. We have a lot of specialists who have been working with me in the department for more than 15 to 17 years. And then this is a surgical team. After surgery, Dr. Dev Pujari is here also with my, she's been my anesthetist for almost 26 years in all the time since I started. And this is my functional neurosurgery team. Some of them are still missing in the picture. Thank you.
That was an excellent glimpse into the advances in DBS and what the future has in store. Thanks to your enthusiasm, you have started a lot of new procedures, and thanks to starting this multidisciplinary TNS, bringing it over to India and taking it forward.
Yeah.
And then I think you really deserve applause for this.
Thank you.
So we will now move forward for the felicitation ceremony. I request my co-chair to join for the felicitation.
Thank you. Oh, thank you so much. Thank you. You're beautiful. Thank you. Without all this colleagues that we